These are two discs that are damaged. They have annular tears with inflammation and herniations. And we're going to fix them both and take care of our patient's back pain that she's been having. She's here in the room with us, awake. Can you hear me?
I'm here.
Good. All right, Dr. Deuk Majin here. We're going to get started. Are you comfortable?
I am.
Good. Now I'm going to give you some numbing medicine to numb things up. You may feel a little pinch, okay? But don't move. Just say ouch if you feel the pinch. That's my hand touching you, okay? Now, how long have you had this back pain for?
7 years.
Try to keep her comfy, okay? All right. You're going to feel a little pinch and some burning, okay? It's normal. Just relax. It's okay. I promise you. We're going to put you to sleep soon. How long did you say you had the pain?
Like 7 years.
7 years. All right. So it's a long time. I did 3 cc's local. Watch out for the needle there, Luis. Okay. If you feel pain, I want you to say ouch. Don't move, but say ouch. And say back or say leg. Ouch back or ouch leg. If it goes down your leg, okay?
Okay.
All right. I don't expect it to, but if it does, let me know. Now, what can we do about the blood pressure? Is pretty much good. 115.
It was a little lower before. I think it'll come down.
I think a little lower is good. All right. So the first thing we're going to do, again, just like with the cervical surgeries, we want to get into the disc through the tear. You know, that's the least traumatic and least invasive. I'm giving you medicine to numb it up, okay? You might feel a little bit of that. That's normal. Okay, just relax. Everything's good. So this is a really amazing surgery because we don't do any damage to anything except we make a cut in the skin. Shot. Good. All right, let's go lateral. So you really want to make sure that your guidance system is accurate, right? For those of you who understand guidance and navigation, we all use our phones nowadays to navigate us places, and our phones are very reliable. Okay, so we're higher than we need to be. So we're going to have to go a little bit further south. And I'm going to just go through the same place I did last time. I'm going to give you a little more numbing medicine, okay? And my goal here is, I know it's a little bit uncomfortable. I'm sorry. Just bear with me for a moment, okay, as I numb things up. My goal is to numb this area up so that I can access the spine through this area. And now we've done a total of 7 local. And she is really quite in great shape, actually. You're in great shape, so there's not a lot of soft tissue back here for me to work with. And that's good. It makes things easier. Yeah, you're doing a good job. Okay? All right, just lay still. Everything's good. Okay, shot. Let's just see where we are. I need to see, you're showing me too much belly. So can we either drop the table, if you can still rotate into an AP, or raise the fluoro, I guess. All right, that's better. Now I need to see the sacrum, so let's go down just 1/4 inch to 1/2 inch. And this is actually a pretty good entry point. I need to make sure, because she does have a disc down at 5-1, which is well preserved. And we're really shooting for 3-4 and 4-5. So now she's got 2 damaged discs, one at 3-4 and one at 4-5. So we're going to go ahead and get over there to those discs now. Try not to move. Try to get her comfortable enough so she's not really moving. So I may go a little bit more medial. Shot. All right. So we're heading towards 3-4, and I still need to do 4-5. And it's interesting because if you look at the iliac crest, it's actually coming through the 4 vertebral body. So it's a good thing it's not the 5-1 disc that's the problem. We may have some trouble getting there. It's actually a disc that's pretty accessible. Again, I think I need to come a little bit further south. You're doing fine. Everything's going well for you, okay? Again, we're just doing the first part of the surgery. You've watched these surgeries before, and you know this is the part that is the harder part. But and everything's going perfect, but once we get through it, you'll be fine. We're going to put you to sleep, okay? Yeah. I just want to make sure we're going in at the right place. Shot. So again, when I say shot, it means take a picture with the fluoro. And I want to aim a little further south for this one. Shot. What's the problem, guys? Shot. So our trajectory is looking pretty good here. I'm in the foramen shot. I could feel it. Are you awake? What's wrong?
No, I'm talking to
Shot.
Yeah.
Let's get an AP, please.
Thank you very much.
So you can see the disc below the vertebral body. I'm at the L4-5 disc. There's one more disc down below. That's the L5-S1. We're not treating the L5-S1. We're only treating the 4-5 and the 3-4, the one above. And on the lateral view, everything is looking good. I'm very close, but on the AP view, once again, everything is looking perfect. So you always have to check 2 views, front, back, and side, just to be safe. All right, go lateral. Now, the L5-S1 disc, the one below, is perfectly preserved. There's no damage at all. It looks like it was when she was born, which makes me wonder, is it a real disc? Or is it a pseudo disc, fake disc, like an embedded disc within bone? Doesn't really matter, except that you don't need to treat it if it's not causing symptoms. So I kind of think it's a real disc, and then it's just well preserved. All right, are you awake? You're doing great. Where do you feel that?
Where did you feel that pain? In your back or in your left? On your back.
Yeah. Well, we found the first of the bad discs, okay? Are you comfortable? Okay. So, have you ever tried to get this pain fixed with somewhere else? Hmm? What did she say?
Only injections.
Injections, yeah. A lot of people try injections to reduce the inflammation and swelling, but they usually only help for a little while, if they help at all. All right. So with the lower back, our incision is always going to be bigger than the neck. The neck is always around 4 millimeters shot. Lower back is usually around 7 millimeters shot. You're doing really good. We're going to put you to sleep soon. We're almost done. You're perfect. Where do you feel that? Huh? Yeah. Yeah, that's her facet. We're almost done, I promise you. And when you wake up, that pain will be gone for the rest of your life, okay? That's why you're here. Shot. All right. I'm happy with that. It feels perfect. Is that it right there? Yep. Yeah. I'm sorry. Is that better? A little better? Yeah. Are you comfortable? So here's Dr. Rafferty. We need to have reliable information. You always have back pain every day? Yes. And it's more kind of around your belt area, right? Yeah. So let me show you. You're going to appreciate this. I'm going to talk a little bit, but you can rest, all right? She has 2 discs that are damaged, okay? The first one is the L45 disc, and the second one is the L34 disc. Now I'm just drawing on the drape. And between these discs are bones called vertebrae, and her vertebrae are fine. People rarely have problems with their vertebrae until they get older, and then they get, fractures, osteoporotic compression fractures. And then that can be a problem, but those aren't even that common. All right, so she has tears in the back of these 2 discs. This is the L34 and L45. And that's where her back pain's coming from. Okay, and so we're going to go in there and repair those tears. She also has tattoos. All right, are you comfortable? How bad is that on a scale of 1 to 10? 10? All right, sorry about that. That was the L45, 10 out of 10. Is that where you typically get your back pain? Yeah. So okay, I apologize. We just found one of your painful discs and confirmed it. So that's good news. When you wake up, that pain will be gone for the rest of your life. That's why you came here. Right? All right. So that was the L45 disc. There's a giant tear in the disc in the back at the L45, and that's where her pain's coming from. And then, of course, I believe that she has 2 discs that are causing her pain, right? How bad is that on a scale of 1 to 10? Huh? 10. All right. Was that where you typically get pain? Yeah. All right. So both concordant, 10 out of 10. I want to tell you, okay, we're going to put you to sleep now. When you wake up, your pain will be gone. You'll be cured. All right. So just count from 1 to 100 out loud. What other languages do you speak? Spanish? All right, count out loud in Spanish for us. We need a Spanish counting lesson today. Keep going, count out loud. All right, keep going. All right. So folks, if we still have the x-ray up on the side view, you can see that I injected dye into 2 discs, and the bottom disc has a gigantic tear. The one above it, not as big of a tear, smaller tear. And the reason why we're seeing on the one above not such a big tear is because a lot of it is tried healing and there's scar tissue there. But both discs caused 10 out of 10 pain. So we're going to fix them both. Keep going, you're doing good. I'm going to start with the L45 and then I'm going to go to the L34. So guide wire goes down. And remember, we're not doing any damage to her body whatsoever except for this little cut right here. That cut is the only tissue of her body actually being cut. Everything else is being spread, not cut. All right, lateral. Perfect. So we got our guide wire in. I'm going to bring the needle out, hold the guide wire in position. You don't want to pull the guide wire out accidentally. You don't want to push it in accidentally. Shot. It looks perfect where it is. Everything okay? Yeah. All right, so we've got our guide wire, and it literally is going to guide my tools down to the bad disc right through the tear. And I'm not going to take any bone out of her spine or any ligaments. I'm not going to do a partial facetectomy like other doctors do when they do microdiscectomy. And by the way, a microdiscectomy won't work for this patient because microdiscectomies only treat, they only treat leg symptoms like leg pain, which she doesn't have. So there is no other surgery for her to have except for a fusion. If I did a spinal fusion on her, I could get rid of her back pain. but I'd have to fuse both discs with screws and rods, and it would be very painful for her and a long recovery with narcotic painkillers. So it's not what you want. She's an active lady. She wants to get back to normal life as soon as possible. And with this surgery, she'll get back to normal life within a few days, probably a day or two. With a fusion, she's going to be laid up for months. So this is the way to go. All right, I can feel the herniation. Very nice, very nice.
Very nice.
You know that. Good for you. My son can impersonate him perfectly. It cracks me up. I can't do it as well. Shot. That's it? Yeah. Shot. So when the patient's asleep and comfortable, I can get this thing in easily, this dilator. Let me do a little more just to be safe. And I can feel this tear, it's big. So, take. Look at that thing, it just went in. So easy. That's because there's a huge tear in the back of the disc. I didn't create the tear, it's there. And that's where all the pain and inflammation is. It's causing her back pain. Now, by contrast, look at the tear at the disc above, small. So it doesn't have to be a big tear. A small tear can cause massive pain. It doesn't have to be a big herniation. A small herniation can cause massive pain. So all these things that the doctors look at on the MRI are incorrect. They shouldn't be trying to figure out if someone's back pain is real because their disc herniation is huge. It has nothing to do with the size of the herniation. It has nothing to do with the size of the tear. What matters is the location of the tear being posterior and in the annulus and the inflammation that's within the tear. Let's take the fluoro out for a moment while we do our surgery here at 045. Thank you, Luis. I got to tell you, I got the best team in the world working with me. And when you have the best people, it makes all the difference in the world in terms of the outcomes. Everything flows safely, smoothly, you know. It almost doesn't feel like neurosurgery, does it? Not like clipping an aneurysm or taking a brain tumor out or doing a complex reconstruction of the spine. This is wonderful surgery for the surgeon, the team, and the patient, for everybody. And it's safe and effective. We don't leave anything in the patient's body unnatural, like metal or plastic. And the patients love it because they heal up almost immediately. All right, we're inside. What? I'm good with that screen. Thank you. So the blue stuff is the degenerated disc, degenerated nucleus pulposus. The annulus fibrosus does not stain blue, and the cartilaginous end plates do not stain blue. The bone doesn't stain blue. The nerve doesn't stain blue. Literally, the only thing that stains blue is nucleus pulposus that's degenerated. I think I still have a piece in there. So it's a very good system for identifying the degenerated nuclear material that needs to come out. And it's degenerated. It looks like we have a little bubble. I'm going to clean it. The degenerated nuclear material is degenerated because of the effect of inflammation on it. Thank you, Luis. So in contrast to the two prior surgeries today, our patient is laying down on her belly, and the other two patients, which were cervical spine, were on their back. So, you doing all right, Doc? No loss of taste, right? You know, what's sad is that one of my friends who's an attorney take this standby. It seems like there's something here on the lens, or it could be, it's on the camera lens, I think. Give me a second, folks. I gotta make a correction here. We have some water droplets on the camera, I believe. Maybe. Do you have a dry one? Or on here? It's weird. Hope this is not a lens issue. Just cleaning the camera. Not yet. Let's see if we can get the clarity we need. So, let me see. That looks good. I don't see anything on the camera. And the scope has those things. We may need a new scope. Let me see. Yeah, there's a problem. See it? See those things?
Big rock, big rock.
This is going to need to go in for repairs. All right. Luis, why don't you
Let me
do your thing. Let me get this disconnected for you. So we're going to change our scope because it looks like the lens may have shifted within the scope. Turn the light source off, please. Yeah, unfortunately, I'm not sure if it looks like the scope's lens. You can show everybody this thing, John. See that?
Yes, we see it.
So within the shaft, you have little lenses, and those lenses are probably knocked out of alignment or bad. So we're gonna change the scope, and we'll send that one off for repairs. As far as what I was talking about, that the repair of the disc is the same whether you do cervical, thoracic, or lumbar. It's just getting to the part of the disc that's causing the problem, the back of the disc where the tear is. That's what differs. No. Depending on whether you go cervical, thoracic, or lumbar. So cervical means neck, discs in the neck. Thoracic means discs in the mid back, and lumbar is discs in the lower back. Okay. So let's be careful with the scope, guys and gals. As you all know, these things are not easy to repair. Any questions from our audience?
Yes, we have a couple. One is from a YouTube viewer asking if there's the possibility of fusion after doing the Deuk laser disc repair.
Yes, there's definitely possibility of doing a fusion after the Deuk laser disc repair, but there's no need to do a fusion. Doing a fusion after the Deuk laser disc repair would be like going out to dinner right after you finished eating at your favorite buffet. There's no need for it. I mean, there's no reason to do it. A fusion is a highly invasive, dangerous, painful, expensive surgery that doesn't do anything more or better than this procedure. In other words, this procedure eliminates the back pain, the leg pain, stenosis, herniation, annular tear, everything that causes problems. So a fusion is unnecessary and quite dangerous. There's no reason to do a fusion after this surgery. Unless, of course, you re-herniate, and 1% of the patients do re-herniate. And if you re-herniate your disc, then, you can either do another laser surgery or you can do a fusion. Either of them would work. So if you re-herniate your disc, fusion is definitely an option. But if you don't re-herniate your disc, there's no reason to do a fusion. This surgery is not a temporary surgery. This surgery is a permanent fix. As long as patients don't, re-injure the disc, and we do have people re-injure the disc. We had a patient who had the surgery done. She was doing amazing, and then she got into a car accident 3 months after the surgery, and the car accident caused the disc to reherniate. So she had to have surgery again, or has to have surgery again, I should say. But yeah, that's trauma. Trauma can cause the disc to re-injure. Any kind of trauma. Take this. All right, things are going well here. We got a new scope. You can all see the difference now. So it's kind of nice. You could troubleshoot that one with us. But at first I thought it was just some water or bubbles on the lens, and then I realized, hey, there's a problem here. By the way, look at the crystal clear view here. That's crazy. That's the tear, folks. That's the annular tear. And look at the pink stuff in there. That's where the inflammation is. Inflammation is pink. If you ever look at a pimple or like a little splinter in your finger, everything is pink because of the blood flow. Now we are inside the disc and you're seeing pink granulation tissue. It's pretty neat. All right, what other questions do you have from our audience? White, please.
The only other question we have is there's a viewer from Germany asking for the possibility of a fellowship. He's given us his email and says he wants to send his
I'm sorry, John,
CV.
your voice is, your volume is so low I cannot hear you. Could you please repeat the question?
Yes, is this volume better?
Much better.
Yes, we have a viewer from Germany asking if there's the possibility to get a fellowship. He has provided his email and would like to send his CV.
Is there a possibility to get a fellowship? Wow. Yes, send it to me, and I will communicate with my German friend. Germans. Yes. I like Germans. Of course I am German myself, part German. More of a mutt, to be quite honest with you, but I was born in Germany, Bremerhaven, so it doesn't surprise me that our German friend wants to learn how to do this surgery. It's a good surgery to know how to do. All right. Good. So I'm using the laser to basically debride the annular tear, and you can see with the soft stuff it just zaps away pretty quickly. With the bigger, harder, more calcified and more collagenized material, it just takes a longer time. But a lot of this herniation is soft, so it's kind of melting away pretty quick, which is good. All right, stand by. I think there may be a chunk of herniation I can grab and make this a little bit safer and faster. A lot of these chunks of herniation are still attached, so they're hard to get out. Laser. The younger the herniation, the faster the laser works on them, and the more scarred up or collagenized the herniation, the longer it takes.
We have another question if you're ready.
I am ready.
Another YouTube viewer is asking, how many discs are you able to clean out in a single procedure?
Great question. The most discs that I can do in a single procedure is 4. There is somebody who I've been talking to that's thinking about doing this. They have 5. The problem with 5, to be honest with you, or more, is that it just takes a long time, and the patient is under anesthesia for a long time. And honestly, you know, the longer the patient's under anesthesia, the higher the chance of having a complication. So I like to do shorter cases, short and sweet, to make sure my patients don't get complications. It's my phone. Don't worry about it. It's out in the hallway. No, I'll be done soon and we'll take care of it then. Yeah, I mean, the truth is, folks, that most people with problems in their back or neck, they usually have 2, maybe 3 discs. Rarely is there 4, and even rarer 5. So I've never seen more than 5 discs be a problem. And like I said, this is a bit of an unusual case, somebody with 5 discs, but they're also from out of town, and they want to come for one surgery and not have to come back again, of course. But I feel I could do their case safely. Now, if I have to go bilateral, which means both sides, because they have leg symptoms on both sides, symptoms like neurogenic claudication, weakness, numbness, pain in the legs on both sides, then 5 disc bilateral would be impossible to do in one surgery. I mean, of course we could do it, but I don't want to do it. It's too long under anesthesia. So I shouldn't say impossible. I should say ill-advised. All right, that's pretty much it. So this is the L4-5 disc. We're just about finished. This was causing her substantial pain, and she called it a 10 out of 10 pain. And you could see that there was a giant tear. Now the next disc that we're going to do is 3-4, and I suspect that we're going to see a smaller tear, and I suspect we're going to see more scar tissue, to be honest with you. Based on that discogram that I saw, I think that next disc we're going to do is more scarred up. That's why the tear is partially healed and not as visible, but I think it was originally a big tear, and it's just more healed than this one. I think that she must have re-injured this one more recently, you know, and that's probably set it off and just made her come in and get it fixed. But these disc injuries, they never heal themselves. They need this procedure to heal. The Deuk laser disc repair is the name of the procedure. Once again, only performed here in Florida, and maybe eventually in Germany as well. What other questions can I answer?
There are no other questions at this time.
Thank you, John. All right. So, let's see here. That's the epidural fat. The nerve root will be just there in that area. Can't see it because it's well padded. Just finish this up. A little lateral. And we will be done at this level. See that little vein right there? Pretty cool, huh? See it? Nice. Thin-walled little vein. We're not going to mess with it. All right, done. laser off. Again, this was L45. Now we're going to move on to L34.
Thank you.
Wait, let me move this. So, one down, one to go. Here you go. And wait, all right, go ahead, roll in. For those of you that are sticking around for the last case, it's a thoracic procedure with a thoracic disc herniation at T45. Whenever you're ready. We don't start with an AP, we always go lateral. Sometime this century. I gotta give Monica a hard time. Okay. Take it. All right. So, put pressure. Now what we're putting pressure on is the paraspinous muscle because we've spread the muscle fibers,
What do you need?
my guide wire, and we are now going to we are going to put pressure because sometimes there's little veins that can tear in the muscle. Muscles have lots of blood flow. All right, take a shot. And, oh, way too far south. Let's go north, 2 inches. Shot. That's pretty good. Can you bring your collimator down a little on the back? It's too much exposure in the back. Shot. All right, next is the L34 disc, which has a tear as well. Shot. Very nice. And you can see the herniation right where the needle penetrates the disc. There's a bulge back, if you guys can see that, underneath the end plate. I wish I had a pointer. Be nice if we had a pointer, huh, John? Any way to point?
No, I don't think there is on my end.
You can't point?
Or-
Yeah, I see a little arrow there, but I don't know. Can
I
you
don't
see
know.
the arrow?
Yeah, I see there. I don't know how to move it though. Oh, you all are moving it.
Shot. Are you able to see the arrow?
Yes, I can see the
Oh,
arrow.
wow. Yeah, put it right there. There. Yes. You had it. There. That's the bulge. That's the shadow of the herniation right there. Damn, you're good. All right. And are our viewers able to see the white arrow?
I believe so,
wonder.
yes.
Huh?
I believe so, yes.
Let's see. Poll them. Ask somebody and see if any of our viewers see the white arrow. Just reply yes if you don't mind, or no. Only honest answers. Okay, so the tip of the dilator where the arrow is, that's where the herniation is. You can see the hernia. Yeah, everything's okay. I'll wait till you put her down a little bit more. Putting someone down doesn't mean putting them down like you think. It means putting them deeper back into the dreamland so that they sleep. And now that we're working on the second painful disc, we're right where the tear is. So I'm about to pass through that painful tear, and she's responding, letting us know that, hey, don't go any further until you make me sleepier. Let me know when you're ready, doctor.
And the viewers are able to see the arrow on the x-ray.
Nice. So you have a new job. You get to point things out. Well, just above the arrow is the guide wire, and to the right of it is the tip of the dilator. Can I proceed? All right, so I'm pushing on her tear. Yeah. See how painful it is? It's so inflamed for her. It's okay. Just take your time. Get her down gently and carefully. But I don't want to move forward because then she's going to be uncomfortable. So we're going to put her a little bit more asleep. And for those of you wondering, well, why don't you just put a tube down their throat? We can't. We want them awake, communicating with us during the beginning of the surgery. Once we've started the surgery, you can't put a tube down their throat. You only do that in emergency situations. So this is a twilight sedation, meaning the patient's sleeping but breathing on their own totally. They have a little bit of oxygen, nasal cannula. We monitor their secretions and their breathing and their airway, and that's about it, their blood pressure. So I'm pushing again. Seems to be better off right there. And this is the most stimulating part right now of the surgery. And then, of course, when I come back with the laser and I start zapping in this area at the end, it'll be stimulating again. So we just need to put her asleep a little more while I feel the tip going through the tear while I do this. Shot? So. But once I'm done, and just as I thought, it went in pretty easy. That means this is a big tear, just partially healed, enough to restrict some of the flow of the dye out so you don't see a giant tear. But there's a big tear here. I knew it. I could tell just by how much pain she had and the appearance on the discogram. It looks scarred up. Shot. So you can see the tube moving down into the disc through the tear. So there is a surgeon in Germany, my good buddy, who's a neurosurgeon and does endoscopic surgery, and honestly, one of the pioneers. And honestly, he deserves more credit. He probably may not even remember me, but our relationship goes back about 16 years. And his name is Sebastian Reuten. Sebastian Reuten. And he's a peculiar neurosurgeon. He's not like the others where he's full of himself. He's a very down-to-earth man. Great man. And he's an endoscopic spine surgeon. But he doesn't do what I do. He does similar. He treats herniated discs and removes herniations, but he doesn't do what I do. And, you know, he's in Germany, and he is a pioneer of endoscopic spine surgery. So if you wanted to have someone in Germany who's good, I recommend Dr. Reuten. Look him up. He's published many papers. And like I said, I've known him 16 years. And he's a funny guy. Bit of an anxious guy, always smoking cigarettes. But, I mean, what a brilliant man, and what a pioneer, and what a brave soul. I give him credit. I really do. Okay. But like I said, I discovered this particular type of surgery, and he doesn't do it, so you won't learn it from him. But he knows how to do endoscopic surgery. And there we are. We are inside the herniation, inside the disc. Reuten was actually probably the first surgeon in the world to do anterior cervical endoscopic fusion. I think he was the first. I had never seen anyone do a fusion endoscopically, and he was the first one. And I remember when he did it. He showed me the results, among other doctors that were there. And like I said, he's a brilliant man, and I have a lot of respect for him. And he is in Germany, and he is German. And if you're in Germany and you want to learn from a German, besides me, I'm happy to teach too, but he is the one. I don't know if he's still around, to be honest with you. It was interesting, though, years ago when I talked to him about Germany and performing endoscopic spine surgery there. he told me that it was very challenging because all the other surgeons would recommend fusion or artificial discs, which are highly invasive surgeries, and that he was like a black sheep, basically, in his community because he was the only one doing endoscopic surgery in Germany. And he was basically persecuted, like literally persecuted, gone after by other surgeons. Shameful by the dark forces, the powers that be. And I don't know if things are any better in Germany or not, but he was really fighting on all fronts. Of course, the patients like it, but you know, he was fighting against the insurance companies, fighting against other surgeons, fighting against hospitals. And you know, surgeons are people that we're not warriors. You know, we're not supposed to be, at least. We're supposed to be doctors caring for people. We shouldn't have to have these kind of fights. Innovative technology that works should be embraced, but the problem is there's so much corruption in healthcare now in every country, and that's what we were talking about. That's what mystified me at the time, was that even in Germany, such a progressive society, that it was virtually impossible to get people in healthcare and the insurances to approve these endoscopic surgeries and get them done. So, I don't know what to say. I'm almost done, so let it ring. But Dr. Roten is a bit of a, deserves the credit of being a warrior and a martyr, if there is such a thing in healthcare. You know, unfortunately, I'll be honest with you, these technological advances like the Deuk laser disc repair endoscopic surgery, these are best for the patient. They're faster, safer, better outcomes, more reliable outcomes. They're just all around better for the patient. But because they are, the insurance companies don't want these procedures popularized because more people will want them and it'll cost the insurance companies more money. So they are fighting tooth and nail to almost criminalize doctors who are trying to make progress in medicine. I mean, if you think about it, they all use the same excuse of, we're not going to pay for this because it's experimental. Well, how is there going to be any new technology and advancement in medicine if it's not, if all of it's going to be called experimental? Everything new will be called experimental. So how are we going to make any progress if everything new is not paid for by the insurance companies and called experimental? You understand? In the past, insurance companies always paid for the new technologies because they were better. And we could see that, and they trusted the doctors. But now they've gotten so greedy they don't want to pay, that they call everything new experimental, and they don't pay for it. So people then have to pay out of pocket, mostly for their surgeries and their treatments. And that just causes a chill effect on the adoption of new technology, not just by the patients of one doctor, but by the entire country. So Reuten was dealing with that in Germany back in the early 2000s when I first met him. And he was doing great things, but he wasn't getting any of the support from the insurance companies and his colleagues because the surgeries he was doing were so complicated and difficult to do. His colleagues did not know how to do them, so all the other neurosurgeons would say that, you know, his procedure wasn't good because they couldn't do it, which typically happens, by the way. Happens all the time. It's the wrong reason, but it happens. Why am I looking there? I should be looking here. All right, we're almost done. 5 minutes, Dr. Rafferty, or less. This is all that scar tissue I told you about earlier. It's a partial heal, but you can see the problem is all this blue stuff wedged in here has created a huge problem. And that blue stuff is preventing this from healing properly. So I gotta open it and clean it. It's a debridement. And by doing so, this patient's pain will go away as the disc heals completely without further inflammation. All right. John, any questions? So we have one more surgery to do.
Yes. One of our Facebook viewers is asking, what is the medicine that you shoot down the tube after you take the laser out?
What is the medicine we shoot down the tube after we take the laser out? So because we're working around the nerves, things can get inflamed and irritated. So we put a little bit of Kenalog in there to reduce the inflammation from the surgery. All right. Most of it honestly falls out. But we do put a little bit in there to reduce the inflammation. Any other questions? These are all very good questions.
No, there are no further questions at this time.
Okay, good. Well, for those of you who have questions, type them up and they will be asked and answered in a few minutes. And we're going to get this patient awake, put her in recovery and let her wake up. And then she's going to end up going home over the next hour. And we'll have our last surgery being done while she's waking up. Alrighty? Boy, that's a lot of herniation in there. That blue stuff, just degenerated nuclear material, degenerated nucleus pulposus. Hey, John, would you reach out to John May and find out if our animation soundtrack is done?
Yes, I can go ahead and give him a call.
Yeah, call or text or email him and tell him I'd like it done latest by tomorrow with the voiceover. I want to get it onto the website and onto our app and start using it in our telemedicine so people can understand. Get it onto our AI platform that we're going to be developing on our website. All right, just about finished. Another minute or two. What a bunch of scar tissue, huh? All the white stuff. All from chronic inflammation. This is her body trying to heal this disc and not being able to. Just like barely healing a little bit. So I took my daughter to lunch on Saturday and we're sitting there having lunch together and she says, "Dad, can we go shoot a gun?" Thought it was pretty funny. Out of the blue. Never shot a gun with her before. Huh? She doesn't shoot anything. But we went to Frog Bones. Anybody been to Frog Bones? Yeah, just 10 minutes away and we went shooting. She shot a 22, got her an instructor, huh? Handgun? Yeah, it was good for her. No recoil, you know, real simple, no safety. But next time we'll probably bring my... Tall? John. Yeah, that's who we had, John. Real good. Sorry for people who are against guns. I don't mean to offend you. Gun safety, yeah. You never know, right? I mean, kids can go to someone's house and there's a gun and, you know, someone can get hurt. But if you know what you're doing, you can neutralize the situation. Yeah. All right. Just about done. Any more questions at this time? Type them up and I'll be happy to answer them for you. Okay, folks? I'm very happy with the way her surgery went. There's the epidural space. The nerve root's going to be right there. And just clean this up right here. We should be good to go. Now she just can't re-injure her back and she'll be fine. Laser off. So we're gonna suck the water and everything out.
Lights on, please.
Good work, everyone. Let me show you guys the incision here for the Deuk laser disc repair. Let me put about 1/2 mil, and let me show you here the incision. Can you guys see the whole surgery was done through this tube? You see this, John?
Yes, we can see it.
So the middle of the back is here, and we came off from the side. Went through the foramen, the neural foramen. That's why the surgery is so amazing, because we're going through a hole that's already there. And there's no other way to get through that hole except with a needle and an endoscope. We didn't take any of the lamina out. We didn't take the ligaments out. We didn't take the facet joint or the facet capsule. We didn't take anything out of the spine, as a matter of fact. We just passed through a hole that's on the side. And that's what's unique about transforaminal endoscopic lumbar surgery, is we're able to do that. But traditional spine surgery doesn't. It makes a big cut in the middle of your back. All right, great work, everyone. Write your questions down, and I'm going to come and answer them for you. We've got one more surgery to go. It's a thoracic surgery, thoracic T4/5, herniated disc with back pain. In a poor young man who literally is just, his whole life has been ruined for the last year because he has constant pain at T4/5 and a small herniation that nobody, anywhere in California, nobody could help him or fix it. They didn't know how. All right, I'm saying no complications. Our blood loss is 1 mil again. And we went from the right side, correct? Everyone agree? Alrighty. Check out the Deuk Spine app as well. It's free.
Come on. I really feel great. I mean, well, before the operation, I could only walk up maybe 100 feet. I had to go back in the house. Now I can walk pretty much 2 miles every morning. In fact, they marvel at me at the gym that I'm able to do what I can do there. I'm kind of an inspiration for a lot of people at the gym.
My name is Greg Spadaro. This is my father, Jack Spadaro. We are from Connecticut. We moved down here. For me, it's been about 20 years. I think my father's been down here a good 24 years now. And we've been two individuals that have kind of suffered with back pain and problems for a good portion of our lives.
My situation started back in 1964. I had an injury bowling, and it was not a serious injury, but someone at the time recommended me going to a chiropractor at that time. And I went to this guy, and I went to see him, and he ended up rupturing my disc. It was the first operation. It was a neurosurgeon in Hartford, Connecticut, named Dr. Scoville. And he did an excellent job, and for years after that I was fine, until I got here in Florida again, and my back problem started again. But we went up to Tampa. I had several laser surgeries done, which actually only aggravated my situation. And then locally we had a neurosurgeon here that became well respected as an excellent surgeon, and he operated on me twice. And my situation only got worse. I was bent over with the pain in my left side for a long time, almost 2 years. And then I heard my son telling me about Dr. Deuk. And so I ended up going up to see Dr. Deuk and explained my situation to him, how I was in such pain and such. And he took an x-ray and evaluated me, and he showed me on the x-ray how my operation actually had come apart. The fusion that they did locally here had come apart, and the nerve was being impinged on.
The pain level got to about an 8, a 9.
The right side of my body from the waist down was pretty much useless and in pain constantly.
The pain was chronic.
It was an aching, stabbing.
It became unbearable. It became where I didn't want to get out of bed. I didn't want to talk to anybody. I didn't want to do anything.
I had the pain every single day in my low back.
It's torturous. I can't go to sleep at night. I can't lay down. I can't sit for too long. Can't stand for too long.
I couldn't sit. I couldn't stand. I couldn't walk more than 50 feet.
It's excruciating.
Sends excruciating pain across my back, gets down to my hands where my hands are numb.
I had no life.
If you are suffering from neck or back pain, the Deuk Spine Institute can give you the relief you need to live your life without pain.
Now I have absolutely no pain.
Not even 24 hours after the surgery was complete, I was able to be how I felt is normal. And it was good.
No scars, didn't hurt at all. You know, when I woke up, it was totally painless.
The next morning, I was up and about and out, dressed on the job.
I have no pain. I'm living my life and doing great things, and I'm just very happy.
It's a great feeling not to be in pain.
Deuk Spine Institute has changed thousands of lives. Isn't it time you live your life pain-free? Log in to DeukSpine.com or call 1-800-FIX-MY-BACK for a free MRI review and consultation.
I feel like a new man again.
And it's thanks to Dr. Deuk. He gave me my life back.
I think that was said before, yeah.
Well, hello there. I'm Dr. Deuk Nation, and the CEO and founder at Deuk Spine Institute, and thanks for joining us for the surgery. We've just completed another endoscopic spine surgery called Deuk laser disc repair, and we broadcast live over the internet through YouTube, Facebook, and Twitter, so you all can watch these surgeries from beginning to end, unedited, live. What's the difference? Well, live surgery is exactly that. We don't edit anything, we don't cut anything out. If there's a complication or problem during the surgery, you're going to find it. You're going to see it with us. This surgery, we had something with the endoscope, where we were seeing some bubbles, and I thought there were little water bubbles or air bubbles, and so I cleaned the ends of the scope and I cleaned the camera, but that didn't fix the problem. Turns out the little lenses inside the scope probably are knocked out of alignment, so we have to send that scope in and get it repaired. When does that happen? Well, it can happen from normal wear and tear, because it's glue that's holding those lenses perfect, and if the glue dries out, remember, these scopes, we use them pretty much every week, so we got to clean them, we got to process them through the sterilizer. They get heated up to kill any bacteria or germs, then they get cooled down, so there's heat, cool, and so that's going to take its toll on any kind of a glue. Plus, who knows, maybe the people that repair them put a glue in there that actually fails after a few months so they can get some more money from us for repairing them. I don't know. But fortunately, it doesn't happen often. Anyway, we have, of course, backup scopes, and that's what we did. We switched out the scope. So we identified the problem quickly. We switched out the scopes, and we'll send that other one off to get repaired. But that's why we do live surgery. So, if you want to teach somebody how to do something, obviously you got to let them do it, but I can't let you guys do the surgeries. But at the same time, this is as close to letting you do the surgery as it gets. You're there, you see everything I, the surgeon, see, my team sees. You have the benefit of all the equipment and visualization of the spine that we do. You get to see all the details that I see, so you get to understand the decisions I make when I make them. So that was a 2-level lumbar, and our patient has had back pain for years, and on and off, getting worse, better as it partially heals. She said, enough is enough, I want to go get fixed. She came here and we just repaired her disc, and I think that pain will be gone forever, for the rest of her life. So it takes an hour to recover from the surgery, and then she's going to go home. And then it takes 1 year for that disc to really get hard and strong. And during that first year, you can actually re-injure the disc and have to have another surgery. And I've seen it happen. It happens in about 1 in 100 patients. So we don't want that to happen to anybody. As long as the patients do what we ask them to do, it usually doesn't happen. But that's the risk of the surgery, 1 in 100 chance of reherniation. If you do get a reherniation, you can have another laser surgery to fix it, or you could do a fusion if that's what you want to do. I wouldn't recommend that, but I would recommend a second laser surgery. All right, what's our first question?
A viewer from Periscope says that he's going to be starting med school soon, and they're worried about paying back their loans. Where do you see the business of medicine heading in the future?
Thank you for asking that question. That's a good one. We don't get questions about the business of medicine and economics of medicine. Medicine has changed a lot. When I was a little kid, my dad was a doctor. I fell in love with medicine because he loved medicine. He was very happy about it. He loved helping people get better. He was an OB-GYN, so he was always delivering babies. That was like the happiest time of people's lives. They had a new baby. So he always told me being an OB-GYN was the best job in the world. And, no matter how hard he worked, and he worked very hard, he would come home sometimes at 2, 3 in the morning after being at the hospital all night, the night before, delivering babies. He loved it. And that energy, that passion, that enthusiasm transferred to me. I had the opportunity to play professional soccer and make probably hundreds of millions of dollars over my career. I was one of the top players in the United States, and I was going to go to Europe and play. But that said, I felt medicine would be a more secure career, and I wouldn't have to leave the States to make a living. So I ended up going into medicine myself. How has medicine changed? Well, in those days, I think it was better because you didn't have the interference of the insurance companies. The interference of the insurance companies with medicine is literally the single biggest problem in healthcare. The insurance companies are the most greedy and evil. Literally, if you watch Star Wars and you watch the Evil Empire, when they blow up the planet Tatooine, I think. Long story short, that doesn't compare 1% to what the evil the insurance companies do. Every day, they deny millions of doctor-ordered treatments for people that are suffering and dying, and they deny those treatments. Cancer treatment to stay alive, they deny paying for it, and the person has to just die. It's horrible, and they're out of control. So as long as the insurance companies continue to make decisions about everyone's health care, they're going to continue to deny health care. They're going to continue to deny paying for things, and your people are going to suffer. So a doctor can treat patients, but you can only treat patients when you have the resources to do that. And if you don't have all the resources you need, then the care you're going to give your patient is suboptimal. Suboptimal care could be as simple as me doing the same surgery I just did, but instead of using a really good x-ray machine, which ours is a $180,000 machine, it's the very best you can buy. Instead of using that machine, I only have access to a cheapo machine, which is an old machine, and I can't really see the needle. Where is it? You know, it's kind of hard, it's fuzzy, it's grainy. Where is that thing? I don't know. Well, you're going to be in the wrong place with that needle because your equipment is not that good. So my concern about practicing medicine in the future for doctors is that they're not going to have the resources or even the training potentially to know how to give patients the very best care so that people can get better with medical care. You know, the only reason why people trust doctors and go to doctors for medical care is because they believe that's the very best care that can be obtained. If that changes, if people lose trust in the doctor's ability to care for them, then they're no longer going to go to the doctors. So what you're seeing is a transformation in healthcare for better or worse, mostly for worse in my opinion, and the insurance companies, the people who stand to profit by denying your care, are winning. And the only way to beat them is to fight them, either at the grassroots level, to get everyone in the country, to get their politicians to force laws to be passed that limit the power of the insurance companies to deny medical care. If there's any question about whether a treatment or test should be done, it should go to a panel of people who, you know, are unbiased and are not controlled by the insurance companies. That's probably the only way to do it. It should be a medical panel. It should be a panel of doctors, not those employed or controlled by the insurance industry, but doctors who actually uphold the Hippocratic Oath and will do what's best for the patients, okay? Insurance companies are not supposed to interfere with medical care. They're supposed to pay for it, and that's it. So what's the future for medicine? Right now, bleak. Bleak, at best. Yeah. I'm sorry, but that is the truth. Does that mean that it's always going to be that way? By no means will it always be that way. I saw today, for the very first time in the news, an article published by the American Hospital Association president. And the president said, for the first time I've ever seen them make this statement, United Healthcare Insurance is making excessive profits because they're denying paying for medical care. Yes, thank God someone else is finally saying it. Hospitals are starting to say it and recognize it as a fact. We need the people to recognize that as a fact. The people need to turn against the oppressor, which is the insurance companies, in order to fight for their health care. If they do that, if people become invested in this fight, then medicine can go back to being good, where we can actually practice with a doctor-patient relationship and not have the insurance company as a wall between us. Any other questions?
Yes, another viewer is asking, with multiple herniated discs, at what point do you recommend a patient to have surgery? And what about treatments prior to surgery, such as a nerve ablation?
Karen Foley, executive.
So the question is, with multiple herniated disc, at what point do you recommend somebody has surgery? It's not the number of herniated discs that I recommend any surgery for. You could have 10 herniated discs, but no surgery is necessary. You could have one herniated disc and need surgery. It's not the number of herniated discs that matter, it's the fact that the herniated discs are actually causing pain or neurological compromise. What is neurological compromise? You know Deb's extension?
1693.
Neurological compromise is basically when the nerves are being compromised. So the nerves carry signals from the brain to the muscles and skin and other areas. And when these nerves get affected by the herniations, they can actually lose their function. Deb, I need coffee, please, half pot. Sorry. So, pain, but that is from the herniated disc, neurological compromise, which is weakness, numbness, tingling, pain down your leg or arm, from the nerve, from the herniated disc causing on the nerve, pain going from your neck up to your head, headaches, and even spinal cord dysfunction. Those are reasons to have surgery, not the number of herniated discs. Now let's just say for a moment the patient has just pain. And that's bad enough many times, trust me. But no neurological compromise, okay? When should you have surgery? Well, if your pain's coming from a herniated disc, it's not going to go away with shots. It's not going to go away with other treatments. The only way to get rid of pain from a herniated or bulging disc is quite literally what you just saw done. The Deuk laser disc repair, repairing the tear. The only other way that works, if it's done properly, which is really hard to do, by the way, is fusion surgery. But 90% of fusions are not done properly by doctors. Okay, there are literally, if there is a fusion, it can be done 10 different ways for the same fusion. And 9 of the ways are going to result in problems for the patient afterwards. So there's really only one way to do the fusion properly, and it has to take into account a lot of variables and factors, and that's the way that I do the fusions. For example, you need a complete decompression. You got to get rid of all the disc and bone spurs that could possibly be pushing on the nerves in the back. You got to restore the normal height of the disc with a large cage. Sometimes you have to do osteotomies as well, which very few doctors know how to do. And by doing the osteotomies, you can recreate the normal curve of the spine. And as long as you use the right length screws, the right width screws, the right kind of screws, and there's so many variables, folks. But you got to get it just right. If you do that, a good fusion will also work, okay? But the laser surgery is the way to go. It's minimally invasive, it's very quick recovery of 1 hour, and it has the highest success rate of getting rid of pain. So, you know, if you can't do the surgery right away, then I would consider doing a shot like an epidural or rhizotomy just to hold you over until you're able to get it done. But in the end, the Deuk laser disc repair is going to be the standard in the world for treating herniated discs that cause pain. It just hasn't spread yet, so it's in its infancy.
That's all.
That's our last question. So 2 of our patients are already gone home. The one we just completed, she's recovering, and hopefully she'll be out of here in about 30 minutes. And we got 1 more surgery coming up. Thoracic T4-5 herniated disc. We're going to do a Deuk laser disc repair. Thank you.